Hi, my name is Victoria Cashin, and I'm going to do a presentation on contact dermatitis for NP 702, fall 2016. I'm going to share my screen. All right, so I have a patient who presented in the clinic with burning, itching, and stinging on the face and complaining that it's red. And history of present illness, she's a 21-year-old that presents with a red rash on her face and neck. She started noticing it, feeling very itchy, burning, stinging upon waking up this morning. She says it's better now, but still a little bit itchy and red. This has never happened before, but she did use some night cream last night that was her roommate's because she ran out. Her roommate doesn't have any rash to this cream, and she's been using it for a while. So the patient did go ahead and take some Benadryl when she noticed the rash about 3 hours ago. She says that it helped with some itching, but it's still a little bit red and itchy and burning. She denies any difficulty breathing, any chest pain, any headache, fevers, anything like that. She also doesn't have any new pets, detergents, or any other new products in her home. For her review of symptoms, she, like I said, denies any shortness of breath, wheezing, or difficulty breathing. She denies any palpitations or chest pain. For her skin, she does complain of itching, redness, and burning on her face and her neck. And she denies any rash or any other skin conditions anywhere else on her body. For GU, she denies any nausea, vomiting, diarrhea, any abdominal pain, or any abdominal symptoms. And for past medical history, for allergies, she has some seasonal allergies, and she has no allergies to latex or drugs. Her current medical conditions are anxiety, for which she takes Lexapro 20 milligrams every night and is managed well by that. She also takes Claritin 10 milligrams every morning for her allergies, and she takes ibuprofen 800 milligrams as needed when she gets her period. She has no major illnesses besides the anxiety. For hospitalizations and surgeries, she did tear her meniscus when she was 17. She had surgery and she's fine now. She had her gallbladder taken out at 18 with no problems. For gynecologic and obstetric history, she denies being sexually active and she is not on birth control. Psychiatric history, she has a history of anxiety and she's managed by Lexapro, like I said earlier. For family history, her father has hypertension and her mother has diabetes. She declines her flu shot, and she did have a tetanus shot in the 8th grade. As far as she knows, she's up to date with all the other immunizations. For social history, she denies any drug use or smoking. She drinks socially on weekends. She's a student at the University of Florida and lives on campus with roommates. For her physical exam, her vital signs are normal. Her height and weight are there on the screen. She is overweight. So for her general appearance, Kathy White is a pleasant, young Caucasian, well-groomed, overweight female. She appears a little anxious. Her forehead and face are moist, and she does have a red rash on her face and neck. Otherwise, she appears comfortable and answers questions appropriately. For her physical exam, so her respiratory exam, bilateral breath sounds are clear. Her cardiovascular exam was unremarkable with a regular rate and rhythm. S1 and S2 are heard. There are no extra heart sounds and no audible murmurs. For her skin, her face and neck is red, and she has a slightly raised rash, but no hives. And then the rest of her body looks normal. So for my differential diagnoses, I have urticaria and allergic contact dermatitis. But I diagnosed her with irritant contact dermatitis, and she also has anxiety. That's her second diagnosis listed. The definition of irritant contact dermatitis is a red, itchy skin reaction caused by contact with some kind of external agent, including any allergens or irritants. That's a Dynamed definition. So for etiology, like I said, it's a injury to the skin caused by anything outside of your own body. So any metal, plant, even any kind of airborne exposure like a perfume, any kind of food, nickel, oils, fragrances, topical steroids, even medications that are topical, powders, alcohol. So here you have a picture of a rash caused by, it looks like a nickel necklace on someone's skin. Pathophysiology, it's important to note that irritant contact dermatitis is different to allergic contact dermatitis. Allergic contact dermatitis is a type 4 hypersensitivity, delayed hypersensitivity that's mediated by T cells. Irritant contact dermatitis is a multifactorial reaction that happens after one is exposed to something that injures the skin. So it's an inflammation that is directly related to the amount of exposure. And it's not immune mediated, but you do get inflammatory cytokines that are released by the T cells when they're activated by an irritant. And it is an immediate reaction. For risk factors, people can be genetically predisposed to this. If you have a history of atopic dermatitis, you're more likely to have irritant dermatitis as well. Psoriasis, there are some occupational risk factors, like if you work in healthcare, you might have allergy, like a reaction to latex or something like that. In food production, maybe some oils, cosmetology, maybe aerosol sprays could give you a dermatitis. So if you work outdoors, paint, electronics. And also there's some non-occupation risk factors like animals, sports equipment, and garden tools. For prevalence, 15 to 20% of the population will develop irritant contact dermatitis in their lifetime. And it is more common in women and children, although it happens throughout all races and sexes. Most common symptoms are burning, itching, stinging, lesions, localized or generalized rash, and it usually happens on areas that are exposed, like your hands, your face, and your neck. So for the diagnosis, it's usually according to Dynamed and evidence in Essential Evidence Plus. It's just by history. So history and a good physical exam, usually you can figure out what the patient did differently that caused the dermatitis. And you look at the pattern of the rash to also see sometimes if it's something that they touched, like nickel, you'll see it right, like a linear pattern in the ear, exactly where the nickel was in their earring. However, if you can't figure it out, patch testing is the gold standard, but usually it's not necessary. For management, we'll start with non-pharmacological. And I love this one with a cool wet compress on your face. And you can also do oatmeal baths or calamine lotion if it was really bad. I don't think my patient will need that, but if it did spread to the rest of her body, she could do that. And then, of course, avoiding exposure to the irritant will prevent this from happening again, hopefully. And then pharmacological treatments. Topical corticosteroid, you want to use a low potency for the face, like a desinide ointment, 0.05%. And then you can also use an antihistamine like Benadryl, 25 milligrams every 6 hours or at bedtime to relieve itching. So it's not really evidence-based, that one, and doesn't always work very well, but some people still use it and some providers still prescribe it. And the patient did take it and she did say that it helped her. So she can take that again if she needs to. For patient indication, obviously avoid the exposure to the allergen and investigate what was in that night cream and what was it that she's allergic to, so she can stay away from that in the future. Maybe even bring it in to me next time she's back, and I can take a look as well and do some research. And then teach good skin hygiene. So wash your makeup off every night. Try not to touch your face throughout the day, not to put oils and bacteria from your hands on your face. And also not to scratch or itch it, because there's always a risk for a secondary infection with that. For medication education, obviously if you develop a rash to the ointment, stop taking that. Or if it gets worse, you know, that's supposed to prevent the rash and make it go down, but sometimes a side effect of an oral a topical corticosteroid is dermatitis. So also watch for easy bruising, thin skin, purpura, ulcers, infections. This probably won't happen to my patient because she's not going to be taking it for very long. But it is a side effect. So I'll also teach her to avoid getting it in her eyes and to wash her hands after using it so that the steroid doesn't stay on her hands. For follow-up, obviously if there's any difficulty breathing or shortness of breath, go back to the emergency room and come back to the clinic if the rash isn't healing or getting worse. If we can't figure this out, if for some reason the steroids aren't working and it's getting worse and she stopped using the night cream but it's spread, definitely we could do allergy testing and refer to dermatology. And then for her anxiety, she is followed by a psychiatrist, and she does have an appointment in a month, so I'll just let the psychiatrist deal with that. And the treatment guidelines I used are the American Academy of Family Physicians, Dynamed Plus, and Essential Evidence Plus. Here are my references. And here are the prescriptions that I wrote, the destinite ointment, and then she already has some Benadryl, but I went ahead and wrote for some more. And that is it. Thank you so much for watching.